Okay, so let's talk about platelet disorders. What do we have here? We have all platelet disorders have increase in bleeding time, BT, mucous membrane bleeding, and microhemorrhages. For example, petechiae and epistaxis. Platelet count is usually low, but may be normal in qualitative disorders. So in qualitative disorders, it could be normal. What are the qualitative? These two are the qualitative disorders, and the rest is the quantitative disorder. Okay, so coming back here, let me just remind one more extra thing here. That we said that if you have a factor deficiency, you're gonna have deep tissue bleeding. For example, hemarthrosis, tendon bleed, deep tissue bleed, rebleed after surgical procedures, things like that. But if you have a platelet problem, what are you going to have? You are going to have superficial bleeding. What do I mean by superficial bleeding? That is your mucous membrane bleeding. Mucous membrane bleeding. For example, you are going to have your epistaxis, hemoptysis, GI bleeding, hematuria, menorrhagia. Okay, so these are all your mucous membrane bleeding. One is the mucous membrane, and second you're gonna have is the skin bleeding. And skin bleeding right here. You have the petechiae, the epistaxis, the ecchymosis, the purpuras, and all that. Okay. So now let's look at the disorders of platelet problem. Okay. So the disorders we have are the qualitative and the quantitative disorders. Because the qualitative disorder, are these two. So let's talk about these two first. So one thing is the Bernard-Solier syndrome, and the other one is the Glanzmann's thrombocythemia. In both of them, as they mentioned, that platelet count is usually low but may be normal in qualitative disorders. So it could be low, but it's more likely normal. That's the platelet count. What about the BT? The bleeding time, they have mentioned it up there. It's going to be increased no matter which disease you're talking about. So just know its BT is increased in all platelet disorders. Makes life easier. Okay. Notes, what are they? So Bernard-Solier syndrome, we have the autosomal recessive defect in adhesion. What is the adhesion? How does the adhesion occur? We have the decrease in G6 GP1B proteins. GP1, and remember, let me just draw that here. You have the subendothelial damage. Subendothelial collagen binds with von Willebrand factor, and that von Willebrand factor binds to platelet via GP1B. Right? So if you don't have this, you have no platelet to von Willebrand factor adhesion. You have this thing. Platelet can bind to von Willebrand factor. So in labs, you will have decrease in platelet aggregation. Platelets can't aggregate because they can't even bind to this thing. And you will have big platelets. B for Bernard, B for big platelets. But the core issue is the first step of the adhesion, which was the GP1B. And that's what they mentioned in the first disorder. Second thing, we have the Glanzmann thrombocythemia. Here we have autosomal recessive defect in aggregation. Next, let's go back to normal. What did we have? The problem was that this was platelet, the 6p GP1B binds to that, and from platelet, once it gets activated, there's GP2B 3A that binds to fibrinogen, and then the next platelet binds, right? So now looking at it, this thing is called aggregation. So now we have defect in aggregation, in which we have decrease in GP2B3As. So you don't have this. When you don't have this, you cannot aggregate. No aggregation. You have decrease in integrin, alpha 2B beta 3. This leads to decrease in platelet to platelet aggregation and defective platelet plug formation. Platelet to platelet is not working. Platelet to 1 Willebrand factor is not working. So kind of see those things, one or the other. But here you have labs which show no platelet clumping. Yes, they're not clumping. They're not aggregating. So no clumping. Simple. That's all for these two qualitative disorders. The quality is bad, although the number of platelets is normal. So now let's talk about the other ones, in which you have the quantitative disorders, in which you have decrease in the quantity of platelets. You have the immune thrombocytopenia. Let's change the color. Immune thrombocytopenia. What is ITP, immune thrombocytopenia? Well, here, all we have is destruction of platelets in spleen in ITP. So you have an anti-GP2B3A antibodies. So you have an antibody against GP2B3A. So when you have an antibody against this, that antibody binds to this and takes it to spleen, and splenic macrophages and phagocytosis occurs. Phagocytose the platelets. That's why you decrease in platelets. Maybe either idiopathic or secondary to autoimmune disorders like SLE, viral illness, HIV, HCV, malignancy, CLL, or drug reaction. Okay. So in labs, you will have an increase in megakaryocytes on the bone marrow biopsy. Remember, the megakaryocytes are the cells that are in the bone marrow that are throwing out platelets into the blood. So you have increase in megakaryocytes on the bone marrow biopsy. Decrease in platelet count because they're getting destroyed. Well, treatment is you give glucocorticoid, which is to inhibit all of this immune system to work. Second thing is you give IVIG. Remember, this was IgG antibodies, which was taking up GP2B3As. So when you give IG, so you're giving IgGs, IV. So the spleen goes and they go into the spleen, and basically they get taken up by the spleen, and we get time, and these don't go much to the spleen. That's sort of a mechanism there. You can give rituximab, and you can also give TPO receptor agonist. What is TPO? TPO is thrombopoietin. Thrombopoietin is going to, if you give this thing, is going to stimulate the increase in platelet formation. And the drugs are eltrombopag, romiplastim, or you could just take out the spleen. If nothing is working for refractory case of ITP, take out the spleen, and you may live. That's for the ITP. Let's move on with the uremic platelet dysfunction here. uremic, as the name says, uremic and uremia platelet are not functioning. Okay, so in patients with renal disease leads to uremia, that uremic toxin accumulates and interferes with platelet adhesion. Okay. That's for the uremia. Moving on with the thrombotic microangiopathies. These are disorders, they overlap significantly in symptomatologies, may resemble DIC, but do not exhibit lab findings of the consumptive coagulopathy, for example, increase in PT, increase in PTT, decrease in fibrinogen, as etiology does not involve widespread clotting factor activation. So they are saying both of them, they resemble DIC, but when you do the labs, in DIC you have increase in PT, PTT, and decrease in fibrinogen, because DIC is a widespread clotting factor activation that leads to all of this. But in here, you don't see none of them. So the labs can tell you difference, but they have overlap of significant symptomatology. Okay, now let's talk about the actual things. What we are talking about here, we have thrombotic, thrombocytopenic purpura. Okay, that's the TTP, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, HUS. So TTP occurs in females. Pathophysiology: inhibition or deficiency of ADAM TS13, which is a 1 milliband factor metalloprotease. When you have deficiency of this thing, there is a decrease in degradation of 1 milliband factor multimers. This leads to large 1 milliband factor multimers, which leads to increase in platelet adhesion and aggregation, which leads to microthrombi formation. So for the pathophysiology, let's go back a little bit. So we have 1 milliband factor, and they are present in multimers like this, and they have to become monomer for them to be degraded. And who does that? That is done by this enzyme, or this thing, which is a metalloprotease, an enzyme which is ADAM TS13. It makes it monomer. That multimer becomes monomer gets degraded. Okay, so when you don't have this, you can't make monomer. When you can't make monomer, you can't degrade them. So multimers remain in the blood. When multimers remain in the blood, what do 1 milliband factor do? They bind to the platelet by their GP1B, right? Yes. So they bind to the platelet and lead to widespread activation of platelets. This leads to increased platelet adhesion and aggregation. So when you widely in a blood vessel, you're activating platelet activation that forms microthrombi formation. Now this is a microthrombi. It forms a microthrombi. So let's read. What does this microthrombi do? Well, microthrombi presentation, it's a triad of thrombocytopenia. You have activated all the platelets, leading to decrease in platelets, microangiopathic hemolytic anemia, microvessels, angiopathic small vessels, hemolytic hemolysis of RBC, leading to anemia. So you have all these microthrombi. RBCs are coming and they're shearing through it. They get destroyed, forming a spherocyte, the Hellman cells, and basically destruction of RBC, leading to microangiopathic hemolytic anemia. Look, when you have anemia, decrease in hemoglobin, schistocytes, helminth cells, increase in LDH because of destruction of RBCs, acute kidney injury, increase in creatinine, and also increase in BUN. Okay. And that, how do we have the acute kidney injury? Because that hemolysis, everything goes to the those small vessels. We have again same thing, microthrombi in the kidneys, leading to acute kidney injury. Now here, very importantly, differentiating symptoms. We would have a triad, all of this triad, which is decreased platelets, MAHA, and AKI. This is a triad. Plus fever, plus neurological symptoms. That is in TTP. Labs, if you were to do labs, you have a normal, as they were saying there. You would have a normal PT, PTT, helps distinguish TTP and HUS. Coagulation pathway is not activated. From DIC, coagulation pathway is activated. Well, they have already talked about it there, so we don't need to put lots of thinking in it. But what is the treatment? Well, treatment for TTP is you do plasma exchange. Okay, you give glucocorticoids and you give rituximab. Okay, so now let's change the color and talk about HUS. Well, HUS, what do we have here? This is seen in children, predominantly caused by Shiga toxin producing E. coli STEC infection stereotype 015787, which causes profound endothelial dysfunction. So what's the cause? In children, Shiga toxin producing E. coli infection, which E. coli 015787 causes endothelial dysfunction. So we have endothelial dysfunction. When we have endothelial dysfunction, we're going to have a triad, which we mentioned. On top of that triad, because we have a GI bacteria, we also have a bloody diarrhea. Okay, and the labs, again, they said the labs, same thing for both. You have normal PT, TTD, and all that crap. The labs, you just have this thing: decrease in platelets, anemia, and AKI. But on top of that, you have bloody diarrhea. But what's the treatment? Well, it's a supportive care. It's going to go away for HUS. Okay. So, when we give a rituximab here, what's the mechanism of rituximab? Rituximab is a monoclonal antibody against B cells, CD20, which are the B cells. So why B cells? Because these are making antibodies, right? They make the antibodies. So we knocking them out, making no antibodies. That's the mechanism for rituximab. Yes, so I guess, yeah, what else I can think of? Well, here, what's going to happen if you have endothelial dysfunction? What's really happening? When you have endothelial dysfunction, Shiga toxin enters the circulation from the bowel and induces capillary endothelial damage, right? And so it enters from the bowel into the capillary, causes damage of the endothelium in the capillary. That damage leads to platelet activation. Platelet get activated. That leads to formation of microthrombi. Excuse me. That consumes. So microthrombi, first of all, you're consuming the platelet, leading to formation of that platelet activation. to consuming the platelet. Second thing, from microthrombi, you're causing erythrocytes to be lysed, leading to anemia. And when you're using all of those platelets, causing thrombocytopenia. But this is the mechanism of HUS. That's all for this section.